Hello friends, today I, Dr. Dheeraj Kumar, is going to take a topic which is considered to be a little difficult by most of us. This is nothing but demystifying ECGs. Now, why is it difficult to interpret ECGs? It's because it involves amalgamation of many concepts. So what we are going to do is approach these concepts one by one and then in the end put it all together. So the first thing that I want to bring your attention to is this cardiac anatomy, as you have known. So now what is important about cardiac anatomy is please understand that what you have been taught in anatomy classes, that the right ventricle is towards the right and the left ventricle is towards the left, does not hold true. And the right atrium is above and to the right, and the left atrium is above and to the left. That also is not true. So when we turn the heart around, this red area is the left atrium. This is the posterior most structure of the heart. It's just in front of the esophagus, where all four pulmonary veins, which are here indicated in red, are coming in. And if you tilt it forward, when you open the chest of the patient, this heart looks like this. Okay, so what does it mean? This means that your right atrium is somewhere here. Okay, this is the rightmost part of the heart, and the right ventricle forms the anterior part of the heart. If somebody stabs you in the chest, the first structure to get injured is the right ventricle, and the left ventricle is, although towards the left, but behind. If you understand this anatomy properly, then it's very easy to understand what the ECG leads will show. Okay, so we next move on to the anatomy as is seen in the CT scan. Now, if you look at CT images, this is a short axis or cut section of the chest. Okay, and in this, if you see, it's always, CT images are always as if they are looking from the ground or from the feet. And if you see clearly, this left ventricle is not in contact with the anterior chest wall. It's slightly posterior and towards the left. The left atrium is the posterior most structure just in front of the esophagus here, somewhere collapsed. And the right ventricle is anterior here, and the right atrium is the rightmost structure, which is also side by side to the right ventricle. If you cut through the heart in a coronal plane, you understand that the right ventricle is in front, behind is the left ventricle, and then this is the aorta and the pulmonary artery crossing each other. This is important because remember, when we look at the lead system, the lead V1 is exclusively, which is just on the right of the sternum, going to record events of the right ventricle and right atrium, thereby increasing its importance in abnormalities of these structures. Okay, whereas V5, V6 leads, which we will talk about it later, will be looking at the left ventricle from the lateral side. Moving on, looking at the lead system, we have limb leads which are attached to the limbs, and we have chest leads which are attached to the chest. So if you remember, orange, black, green, yellow in an anti-clockwise direction, you will be able to understand how these leads are to be attached. Orange to the right arm, black to the right leg, green to the left leg, and yellow to the left upper arm. And of course, V1 to V6. Now V1 is on the fourth intercostal space, just lateral on the right hand side of the sternum. Is it easy to get to the fourth intercostal space? Well, yes, you can always palpate the most prominent part, the manubrium sterni, which is adjacent to the second intercostal space, and count downwards and to the fourth intercostal space. Just to the left of this fourth intercostal space, to the left of the sternum, you get V2. V4 is put first before V3. So V4 is in the along the mid clavicular line in the fifth intercostal space. Once you put V4, V3 is just in between V2 and V4. Now V5 is in the fifth intercostal space along the anterior axillary line, and V6 is in the fifth intercostal space along the mid-axillary line. Why is this important? Because if you do not place these leads properly, it may lead to distortion of what kind of complexes you are going to get. Next thing is, what about the normal conduction system of the heart? The heart has got an SA node. This is also called the pacemaker of the heart. Why is it called the pacemaker of the heart? It's because this depolarizes at a rate which is faster than the other structures. So therefore, where is it located? Well, it's located up. It's located at the junction of superior vena cava and the right atrium, and it's an oval sort of structure on the epicardial surface. From there, the impulses arise. First, what they do is they activate the right atrium because it's the most adjacent structure. And after activating the right atrium, they travel to the AV node. But meanwhile, a few fibers leave from the right atrium and go on to the left atrium. These are also called as Bachmann's bundle. Remember, the left atrium is a posterior most structure. So the right atrium gets activated first. Towards the end of right atrial activation, left atrium gets activated. Then the impulses reach AV node, which is at the antero-inferior part of the right atrium, just near the tricuspid valve. And from here, there is a delay here. Why is there a delay here? It's because the body wants the atrium and the ventricle not to contract simultaneously. It wants the atrium to contract first so that the ventricles fill more effectively, and then the ventricles to contract later. And how is this ensured? It's ensured by extremely slow conduction and in the vicinity of the AV node. AV node introduces a delay of 0.12 to 0.15 seconds. After that, from the AV node arise a thick insulated bundle. These are insulated because it makes sure that the electricity goes on fast in a particular direction. It's called the bundle of His, which then leads to a split into left anterior fascicle. There's one left posterior fascicle, which is not shown in this diagram, and then the right-sided bundle. So what happens is this all is towards the left side of the septum. Why is it important? We will see in the morphology of the QRS why this bundle exiting out on the left side more than the right is important to understand the morphology. Then these bundles give rise to Purkinje fibers, which are the fastest conducting fibers, and they lead to depolarization or activation of the ventricular mass. One key thing that you must understand is Purkinje fibers lie on the endocardium. Remember, the heart consists of endocardium, myocardium, epicardium. Epicardium is the outermost part, and pericardium. Pericardium is generally electrically inert. Therefore, generally pericardial diseases don't produce significant electrical abnormalities. Endocardial may by pressure changes, myocardial certainly do, and epicardial do as well, but not pericardial diseases. So the depolarization occurs from endocardium to epicardium. Therefore, the P waves and the depolarization of the right atrium and the left atrium, the atrial structure is represented on the ECG as P wave. The traveling of impulses right from SA node till the ventricle is represented by this light blue or sky blue line, which is nothing but actually the PR segment, which then comes the depolarization of the ventricular mass proper, which is nothing but the QRS. The ST is the time when the heart is at rest and repolarizing is represented. Everything that gets activated or depolarized has to get repolarized. It is basically T waves. U waves have got an uncertain etiology. People say that it is due to some mid-myocardial M cells which get depolarized towards the end. Although the etiopathogenesis or genesis of U waves is not important because it's disputed, U waves find a very practical significance in many of the myocardial disease and many of the diseases of the heart. So we will look at this as well later on. Now we look at the basic intervals. Now Remember, there are three things which you need to understand. What is a segment and what is an interval? An interval includes a wave from one wave to another, whereas a segment is an isoelectric part. So a PR interval will be from the beginning of P wave to the onset of QRS, or if there is no Q, to the onset of R. But the PR segment is from the end of P wave when it is isoelectric to the onset of QRS. Similarly, QT interval is also important. It's from the beginning of QRS till the end of T wave. Whereas ST segment, it's basically isoelectric. Iso means zero movement. And that is from the end of QRS till the beginning of T wave. So the segments are not important. Intervals are very important. The normal in PR interval is generally ranging from 0.12 milliseconds to 0.20 milliseconds. Normal QT interval is generally less than 0.44 milliseconds in male and 0.46 milliseconds in females. The RR interval is basically time between the two QRS complexes, and that decides the heart rate. Okay, it's normally around 600 to 800 milliseconds. Now, let us look at the ECG paper. This is very important to understand. Why is it important to understand? Because this is how you are going to be able to calculate the rates. Now, one large square in the ECG paper, you will have small squares and one large squares. The smallest square, the small squares account for 0.04 of a second. Obviously, 5 small squares make one large square. 0.04 into 5 is 0.2 seconds. It is very intuitive that if one large square is 0.2 seconds, 5 large squares are 1 second. Therefore, if you calculate the number of QRSs in 15 large squares, that means you would be knowing how many beats are there in 3 seconds. Multiplied by 20, you can get the heart rate. This is especially important when the QRSs are coming at irregular intervals in atrial fibrillation. Similarly, on the y-axis is the voltage. So 10 millimeters includes 1 millivolt. So 0.1 millivolt is one small square, two small square is 0.2 millivolt, 10 millimeters is 1 millivolt. So both these things are important. Along the x-axis are the times, along the y-axis are the millivolts. Okay? Understand. The Higgs axial system has got pairs. Lead 1 and AVF are a pair which are perpendicular to each other. AVL and lead 2 are a pair in which AVL is perpendicular to lead 2 and AVR is perpendicular to lead 3. So these are the leads and there is a relationship between them. This relationship we will use very favorably to derive axis. The thing is how to describe any ECG. Well, it's very simple. We talked about P waves. Well, we talked about QRSs. We talked about all these, but how to put it together? Every ECG, you need to describe 8 parameters. First is where is the P wave arising from? If it is arising from sinus node or not. We will talk about what P waves, how do you make that out? If it is arising from sinus node, you call it sinus rhythm. And then you look at conduction in the entire ECG. If every P wave is followed by a QRS. If every P wave is followed by a QRS, you call it a 1:1 conduction. 1 P wave to 1 QRS. Then you talk about the rate of the heart rate. So how do you do it? Very simple. Remember, you can use a coarse formula. The number of large boxes between two R waves is calculated, found out. It's pretty easy to see. 300 divided by that number gives you the rate. If you want to be more accurate, then you can use 1500 divided by the number of small R boxes, or I told you another method, that is 15 large squares which constitute 3 seconds. In that, how many QRSs are there, you count and you multiply it by 20. Then you describe the P wave. What kind of P wave is it? Then you try to tell us the PR interval. I told you already that PR interval normally varies from 0.12 to 0.20. If it is greater than this, that is also abnormal. If it is lesser than 0.12, that is also abnormal. Then you talk about QRS axis. What kind of QRS axis is there? We will see that in the later slides. Then you talk about progression. I just showed you, because of the position of chest leads, how the progression takes place. Then you talk about STT segment, whether there is abnormality in STT segment or it's a normal STT segment. And then you calculate QT interval. We talked about the intervals, PR interval and QT interval. There is a correction factor and we will talk about it later. Arising from sinus node, that is for sure. Now normal P wave is less than 3 small squares, and 1 small square was 0.04 seconds. 3 small square would be 0.12 seconds. If it exceeds 3 small squares, then you know that there is some delay in the atrium and atrial depolarization. There is some abnormality. Similarly, normally P wave are positive in left-sided leads. One, AVL sometimes may not be positive, may be equiphasic, but lead 1, lead 2, V4 to V6 definitely are positive. And P wave is normally totally negative in AVR. Biphasic, we talked about in V1, and I've given you the explanation as to why it happens. Then it is always less than 2.5 millimeters or 0.25 millivolt in amplitude. This is very important to understand, that it's not only the time parameter but also the voltage parameter that are important. PR interval always from 0.12 to 0.20. If it is more than 0.20, there is a delay in conduction. We will look at it in later lectures, what these delays can take manifest in form of, and less than 0.12 is also abnormal. Okay, so PR interval is also to be seen. Now we look at the QRS. Now we have dealt with P, we have dealt with PR. Now we are looking at the ventricular depolarization. Before we look at the ventricular depolarization, how to name a QRS? Well, if it is you generally get a small Q and then an R and then probably an S or no S. If there is a small Q that is only 1 or 2 millimeters deep, then it's a small QR. The first negative deflection is always called a Q. The first positive deflection is always called an R. If it is a deeper Q, that means more than 2 or 3 millimeters, then it's a capital QR. An R which is less than 3 small squares is a small r. Okay, and the second negative deflection is called an S. So the first negative deflection is called a Q, the first positive deflection is called an R, the second negative deflection is called an S. If there is another positive deflection, as is seen here, it's called R dash. If it is larger than the first R, that's called RS, capital R dash. If it is smaller than the first R, and this one would have been larger, it would have been called a capital R, capital S, and small r dash. Okay, so this is very important. You can get an only R, you can get just an RS, you can get small r and S, but you should know how to name them. Now, why do you get this QRS? Now, very important is, if we go back to the conduction diagram, we realize that the bundle of his comes here, and there in the left side of the interventricular septum, it splits into the right bundle and the left bundle. It is here where the insulation breaks, and this leads to depolarization, always from a place where the impulse arises away from it, so from the left to right. Now we remember that the lead which looks at the right-sided activities, the job that has been given to this lead is V1. So whenever there is a initial depolarization from left to right, it's coming towards V1, it leads to a positive deflection in V1. That means there's always a small r in V1. Whereas, because there is this depolarization is going away from left to right, the left-sided leads actually have a small q. This small q is called the septal q, and this is why it always occurs in the lateral leads. So V5, V6, 1 AVL show depolarization, small q, due to septal depolarization. What is the applied part of it? If you get q in V1, V2, V3, it is abnormality. There is some abnormality in the septum. Probably an MI has occurred in the septum. That's why the depolarization is not happening in the normal way. In normal ECG, you should never get Q wave in V1, V2, V3. There will be a small r followed by Q, in a small r followed by S in V1, and V2, V3 will be having a slightly increasing r and decreasing S. The second depolarization, once septum is depolarized, now what happens is the bulk of right ventricle and left ventricle must be depolarized. So both get depolarized, but which has got more muscle mass? Left ventricle has got more muscle mass. So predominantly, because this area, right ventricle is paper thin, 1 or 2 millimeters, and left ventricle is 8 to 9 millimeters thicker. So predominantly the vector is going towards the lateral leads, V5, V6, 1 and AVL. So you get positive R waves in V5, V6, as I told you. Because the net is going away, you get a negative wave, S wave in V1. And the last part is the terminal part, where it is going to the posterior-basal segment, coming back like this. So this again produces a positive deflection in V1, and it produces a negative deflection because it's going upwards, away from V5, V6 towards AVL and away from lead 1. So this posterior basal brings the QRS back to isoelectric line. So we have the ventricular depolarization takes place in three parts. The septal depolarization, left to right, then the bulk of ventricles get depolarized, which creates a entire axis towards the left side, and then there is a terminal depolarization in the posterior basal segment. So the second method is based on a very interesting phenomenon. You have to see the lead where R and S are equal. Can you see R and S are equal? Whenever R and S are equal, or there is minimal deflection in a lead, remember that the actual vector lies perpendicular to it. And I told you about three sets of perpendicular leads. 1 and AVF, 2 and lead AVL, 3 and AVR. So first thing is find the equiphasic lead. Second thing is look at the lead perpendicular to it, and then observe whether the QRS is in the same direction or opposite direction, and you can come to the axis. I'll give you an example. Now look at the top half of the figure. You look at AVR, it is equiphasic, no doubt. We know that AVR's perpendicular brother is lead 3. Lead 3 is positive. We know lead 3 is in this direction, 120 degrees from lead 1. 120 degrees is beyond 90 degrees. That means that this is a right axis deviation. Had this been a deep S rather than an R, and AVR was the same, then we could have said, okay, AVR is equiphasic, perpendicular to it is lead 3, but here it is negative, means the direction is just opposite to lead 3. That means from 120 degree, the supplementary angle is minus 60 degree, means it's a left axis. But every time it is very difficult to find such leads. So the first method of two perpendicular leads and looking at the net vector is an easier method. It will get simpler if you keep practicing on different ECGs. Now we look at the repolarization part. So P wave, PR segment, QRS, these are all depolarization where activation of the heart occurs. But what about the processes to get the heart back to resting state or repolarization? That starts from J point till the end of T wave. So there is one question. Normally I told you that the heart depolarizes from endocardium to epicardium. So whenever an impulse goes towards a lead, it leads to a positive deflection. That was also something basic that I told you. But when the repolarization or coming back to rest phenomenon is started, it is just the opposite. It starts from epicardium to to endocardium. And why is it so? Because the cellular cells here recover earlier than the endocardial cells. So now this was a positive electricity coming towards the ventricle. This is a negative electricity going away. So two negatives make it a positive. Therefore, repolarization leads to repolarization in the opposite direction of depolarization leads to a double negative, or rather a positive, which means that T wave is always in the same direction as QRS in the normal patient. And if this rule is not followed, you can very well imagine that there is some problem in repolarization. So it is not a normal ECG. If QRS and T waves are discordant, if QRS is positive, T wave should be positive. QRS is negative, T wave should be negative. If there is a discordance, then there is abnormality in either conduction or repolarization that you must come to know. Then again, you look at this action potential diagram. Remember your physiology class. Remember that ventricular myocyte has a phase 4 wherein which it's relatively at rest. Suddenly there is a spike which is phase 0, which is due to sodium channels. Then there is a slight transient leakage of potassium channels because of transient potassium channels. And then there is a phase where there is not much activity, where in which calcium goes in and potassium seeks out. And then finally, after this phase comes a phase when rapidly potassium comes out of the cells. That was phase 3. This same thing happens in the ECG as well. Phase 0 is responsible for the rapid upstroke in the QRS. The phase 1, which is due to transient potassium channels, is responsible for the J point. J point is nothing but the point where the end of QRS meets the isoelectric ST segment. The phase 2, where nothing much is happening, is basically represented by the ST segment, because there is no leakage, net leakage of inside or outside of the ions. So this also leads to a rest. And then comes the repolarization, which is potassium driven, and that leads to T wave. What is the direct implication? If you have a sodium channel blocker, it will prolong QRS because QRS is dependent on phase 0. If you have a calcium abnormality like hyper or hypocalcemia, this segment, which is due to calcium, will change. Suppose there is hypercalcemia, more rapidly calcium will come in, and this amount, duration of this isoelectric time will reduce. Quickly it will reach this point. And if hypocalcemia occurs, slowly it will depolarize, and this phase 2 will be prolonged. And everything to do with potassium is related to T wave. It's very well known. So T wave, potassium is responsible for T wave. So if there is hyperkalemia, there's peak T waves. If there is hypokalemia, the T waves become much more flattened. So this is in nutshell the way to understand how electrolytes and some antiarrhythmic agents cause abnormalities in the ECG. Now looking at the QT interval. We talked about QT interval right in the beginning. Why is QT interval important? It depicts the entire depolarization and repolarization of the ventricle. Indirectly tells you about the health of the ventricle. Therefore, QT begins from the QRS and ends at the end of T wave. Normally, this is easy to calculate, but the problem is that at faster heart rates, the QT needs to be corrected with the heart rate. So if I'll give you a broad way to find out whether QT is normal or not. If this QT is less than the succeeding RR, so this is RR, this is the QT, obviously this is less than half of the RR, then you don't need to worry, you don't need to calculate QT at all. You know it's normal. If you feel it is more than half, then you have to calculate QT. How do you calculate QT? Very simple. You count the number of small squares from the beginning of QRS till the end of T wave, and also count the number of small squares from one R wave to another R wave. Now that number of small squares is multiplied by 0.04. Suppose you have 8 or 10 small squares between two RR. So 10 into 0.04 will be zero point 0.4, and square root of zero point 0.4 you can find out somewhere around 0.89. And in the numerator, you look at the number of small squares from the beginning of Q wave to the end of T wave. That is also simple. Suppose there are 7 or 8 or 9 small squares. 9 into 0.04 is 0.36. 0.36 divided by square root of RR. This is very easy to calculate. Normally in men the QT interval should not go more than 0.44, and women it should not go beyond 0.646. Why is it so? Why is QT more in women? Because of a special potassium channel called HERG potassium channel. Therefore, whenever QT occurs, there is another concept which is very important to understand why QT is significant. Up to here, the ST segment, the heart is in absolute refractory period. That means you can give any impulse and it will not cause any abnormality. But at the T wave, there's a relative refractory period. The heart is trying to recover. Channels are current is already flowing in the heart. If there is an abnormal external stimulus on the T wave, it can cause a dangerous arrhythmia and kill the patient. Therefore, when QT prolongs, the tendency of this arrhythmia increases, and when QT prolongation leads to some kind of an arrhythmia, any kind of impulse falling on the T wave, it leads to polymorphic QRS morphology, means changing in axis as well as morphology. It's a very dangerous ventricular tachycardia which can kill the patients. So you have to be very careful in QT prolongation. You should know that some congenital causes of long QT syndrome. There are drugs which prolong QT like azithromycin, HCQS, macrolides, and of course you need to keep a list. Azelastine, some antihistaminics are there, and you should also know that these electrolytemias can also cause QT prolongation. Hypocalcemia is a very dangerous cause of QT prolongation. So if you know all this, then you can go ahead and correct this problem and save the patient from dying due to some kind of arrhythmia. Now there are some variants of ECG as well. Normally we say that ST segment is isoelectric, but in some young patients in B, C and D, 0.1 to 0.2 millimeters of elevation of ST segment may be there. This is a benign variant. This is not an MI. So go back and ask the patient whether he actually has chest pain or not. If he doesn't, then don't label it as MI. You call it as a juvenile pattern or benign pattern. Here, in stark contrast, the J point is elevated by more than 2. It's clearly an MI. Please do not label. And of course, the QRS morphology is also much broader. So therefore, it's clearly an MI and you go ahead and treat it. Now, this is an ECG which we will use as an example to report. This ECG is, let's say, of a 40-year-old male who comes to you and he says, Doctor, please report my ECG. First thing that I told you is to find out whether this patient has sinus rhythm or not. Lead 2, lead 3, lead AVF have got positive P waves there, and lead AVR has got negative P wave, a bit equiphasic kind of a P wave here in AVL. So this is clearly arising from SA node, from top to bottom, right? That is done. Now every P wave is followed by QRS. Every P wave is followed by QRS. So sinus rhythm with 1:1 conduction. Now let us talk about the P wave morphology. P wave morphology is normal. It is curved. It is not more than 2.5 squares. It is not more than 3 squares in duration. So it's a normal P wave, and it is biphasic in lead V1. So it's a normal P wave. Then we talk about the axis. Now axis again, remember, then we talk about PR interval. Now PR interval is from beginning of P wave to beginning of QRS. ECG. This is called standardization. When you go to this standardization, it's very important to note is to look at the QTC. QTC is very simple to calculate. In this, if you look at QRS onset to the end of T wave, there are 8 small squares. 8 into 0.04 comes out to be 0.32. Remember, between the two RRs, there are 20 small squares. That is nothing but 4 large squares. 4 into 5, 20. Each small square is nothing but 0.04 seconds. You can whip out your calculators. 0.04 into 20 is nothing but 0.8. Square root of 0.8 is approximately 0.89. 0.32 divided by 0.89 is 0.36. Now, what is very interesting that you must always notice that we need not have done it here. RR interval and QT. QT is obviously less than RR interval, and therefore this patient will be having a normal QT. People have described short QT syndrome of less than 0.32, but it is not a properly described entity, so you don't need to worry about it. If QT is less than 0.44, you are absolutely safe and you don't need to think much. Now a few examples. Now this is an ECG of a patient and you are reporting it. What do you see? What is the axis? Well, it's very simple. First of all, you look at the P waves. P waves are positive in 2,3 AVF, negative in AVR. There is 1:1 conduction, one P wave followed by a QRS. Obviously, this is nothing but a sinus rhythm with 1:1 conduction. Now look at the axis. Lead 1 here has got a deep S wave as compared to R wave. So lead 1 is not going to get depolarized from right to left as usual. It is going to be depolarized from left to right in this case. And therefore, lead 1 is negative, lead AVF is positive. You know that lead 1 is pointing towards right, AVF is pointing down towards the feet. Resultant will be in this region, and therefore this patient is going to have a rightward axis because lead 1 is pointing towards the right. The other thing that you need to see is that you see here classically V1 has a positive QRS. We saw that V1 has a small r and negative QRS in normal ECGs. But here V1 has positive QRS much more than V5, V6. V1 has been in charge of right ventricle, looking at right ventricular and right atrial activities. So if V1 is positive, QRS is due to ventricle, that means right ventricle of the V1 of this patient is very strong or hypertrophied, and we always talked about T wave being in the same direction as QRS. If there is an abnormality in the heart, then this rule is broken. Therefore, this patient has right ventricular hypertrophy, because of which repolarization of the right ventricle is improper, and there is T wave inversion and even ST segment which is not normal in V1, V2, V3. We will deal with this in the later classes, but this is nothing but right ventricular strain. That here is a box, a signal box. This signal box will indicate how many, whether the voltages are depicted correctly or not. Always this should be 2 large boxes. If it is less, that means half standardization, wrong QRS complexes you will get. And here there is every ECG paper always has the speed written 25 millimeters per second. If it is at double the speed, you will get wrong interpretation. We use the double speed in certain cases where P waves are not clearly visible, just to bring them out. In a nutshell, the final thing that I need to tell you is that ECG analysis is to be done in a systematic way. Look at the origin of P wave, look at the relationship of P and QRS, talk about the PR interval, talk about the morphology of P wave, then comment about the axis of QRS, then comment about the progress of QRS, then talk about STT, whether they are following the rules or not. ST should be isoelectric, T wave should be in the same direction of QRS, and finally talk about the QT interval, if QT interval is normal or not. This will help you to interpret normal ECGs. We will meet next time and discuss some of the abnormalities that you may encounter in your ECGs. Thank you.